Good afternoon, ladies and gentlemen. Good morning, one day in advance to our friends in New Zealand and Australia. Good evening, Hong Kong, and good morning to our friends in the States and Canada. Welcome to the Faculty of Dentistry of the Royal College of Surgeons in Ireland's webinar entitled Back to School in the Time of COVID-19, an International Perspective. I'm Professor Albert Leung, Dean of the Faculty of Dentistry. The Faculty of Dentistry of the Royal College of Surgeons in Ireland was founded in 1963 with the core mission of advancing the science, art, and practice of dentistry by promoting education, study, and research. With this in mind, the faculty has brought together important leaders, movers, shakers in the dental education world around the globe from 4 different continents: Europe, North America, Asia, and Australasia, to discuss this pertinent subjects because COVID-19 presents many challenges, not least in the dental schools. We shall start off today's webinar with greetings from the CEO of the Royal College of Surgeons in Ireland, Professor Cathal Kelly. Then we shall have some short presentations about how the different dental schools manage and get into the new routine recovering from COVID-19, which start off with number 1, Professor Chris Stradwin, Dean of the Dental School, University of Plymouth, UK. Then Professor Alistair Sloan, Dean of the Faculty of Dentistry, University of Melbourne, Australia. Then Professor Corrado Paganelli, Dean of the Dental School, University of Brescia, Italy, and Chair of the Forum of European Dental Deans. Then Professor Mary McDougall, Dean of the Faculty of Dentistry, University of British Columbia, Canada. Then Professor Mark Letter, Dean of the Faculty of Dentistry, Creighton University, USA. Then Professor Syed Bakane, Dean of the Hamdan bin Mohammed College of Dentistry, Dubai, UAE. And Dr. Christine McCreary, Dean of the University College Cork Dental School in Ireland. After these 7 presentations, this would then be followed by a panel discussion of all the participants, chaired by me, Professor Albert Leung, Dean of the Faculty of Dentistry, Royal College of Surgeons in Ireland, and Professor Chris Lynch, our Vice Dean, will be monitoring the questions that you have sent in to the panel. Following the panel's discussion, we shall have 3 more presentations from Professor Keung Leung, Professor of Periodontology, University of Hong Kong, Professor Kyle Lyons, Professor of Restorative Dentistry, University of Otago, New Zealand, and Dr. Will van der Sanden, Program Director, Radbourne University Medical Center, Holland. Please submit your questions during the first sessions of the presentations for anything to be discussed. Please also visit the faculty website to learn more about us as well. In particular, we highlight that we have moved our Diploma of Primary Care Dentistry and membership of the Faculty of Dentistry examinations completely online, and we welcome candidates from anywhere in the world. I hope you enjoy and find this event beneficial. Now, over to my colleague, Professor Chris Lynch.
Hello, my name is Chris Lynch, and I am the Vice Dean at the Faculty of Dentistry in the Royal College of Surgeons in Ireland. Before the presentations begin, it is my privilege to present Professor Cathal Kelly, who is the Chief Executive Officer of the Royal College of Surgeons in Ireland, who will address us now.
Hello from Dublin, from the Royal College of Surgeons in Ireland. I'm really delighted to welcome you all to this Faculty of Dentistry webinar entitled Back to School, an insight into how dental schools are adjusting to the COVID-19 era. While the world in general has been significantly affected by COVID-19, the education and training of students of dentistry at both undergraduate and postgraduate levels has been significantly disrupted. There's a lot of confusion, concern, and as yet many unanswered questions about the future safe practice of dentistry and the delivery of dental education in this new normal. We don't have all the answers yet. The aim of this webinar is to bring together friends of the Faculty of Dentistry at RCSI, leading national and international opinion leaders in dental education, to share information and advice on practices they are adopting in their own schools, and hopefully we can all learn from each other. I welcome the Dean of the Faculty, Professor Albert Leung, and the Vice Dean, Professor Chris Lynch, who will coordinate and deliver tonight's events. The Faculty of Dentistry at RCSI was founded in 1963 and has the core mission of advancing the science, art, and practice of dentistry by promotion of education, study, training, and research. The faculty has developed significant and important links with centres around the world. The Faculty of Dentistry at RCSI has significant expertise in dental education and has made recent innovations which may well be of interest to an international audience, including the development of an online diploma of primary care dentistry and membership of Faculty of Dentistry examinations available to people anywhere in the world that can be taken from their location of choice, including their own homes. A faculty affiliate membership, which offers contemporary and current CPD, which is also available online. A regular CPD morning held on Saturdays on an almost monthly basis, again online. The faculty also has considerable expertise in delivering links, memorandum of understanding with overseas centres, including the ability to accredit, quality assure specialist and postgraduate training programs, and deliver specialist level fellowship examinations where appropriate. There is a great Irish expression, Ní neart go cur le chéile, loosely translated as, there is no strength without unity. Hopefully by sharing information and opening dialogue across international borders, we will all emerge stronger and able to face the challenges of the current crisis. I hope very much that you enjoy this event. Please stay safe and well, and do stay in contact with RCSI and the Faculty of Dentistry if we can be of any assistance to you as we move into this new normal. Thank you very much.
I would now like to introduce Professor Chris Treadman, who is Professor of Restorative Dentistry and Head of the Peninsula Dental School and the incoming Chair of the Dental Schools Council UK and Ireland.
Thank you to the Faculty of Dentistry for inviting me to discuss COVID-19 and dentistry in the UK. Here we see a picture of me on the right in the clinic, just about to undertake an aerosol generation procedure. In the middle, we have our Director of Clinical Dentistry, currently undertakes some research around aerosols in the clinical and open plan clinics. And on the left-hand side, my nurse being fit checked. We face some key challenges and still facing some key challenges. These include staff and students and minimizing risk and putting safety first. Patients, clinical needs and vulnerability. Aerosol generating procedures, particularly around open plan clinics. Ventilation, building access, increasing our simulation facilities and skills for our students, and administration. In the UK, practices were allowed to open on June the 8th, having been closed down for several months. University campuses are also stepping forward and going into the reopening phase. Very much from the beginning, we went to an online teaching platform and now are starting to move towards blended learning. We've also established clear standard operating procedures for aerosol generating procedures and non-aerosol generating procedures. In terms of actions, we've taken actions around staff and students, particularly with risk assessments and making sure no one's at risk of getting COVID-19, modifications put in place for staff who are high risk, personal protective equipment, and of course, staff and student wellbeing. In terms of patients, we've prioritised them according to their clinical need in terms of low and high, and also then give them a COVID risk score, which is based on low risk, high risk, or unknown risk. And based upon that, we've established protocols for restarting their treatment, which can be seen clearly in the table. We've been permitted and guided by the Faculty of General Dental Practitioners in the UK and the College of Dentistry with a clear guidelines for doing aerosol generating procedures in practice. From pre-appointment screening to patient attendance, to actually during the treatment, then after treatment. We have a clear set protocol. I particularly pick out the Faculty of General Dental Practitioners in the UK here because they've done a comprehensive and useful guidance for doing this. In dentistry, the key problem we have really is around aerosol generating procedures. In practice, it's been okay to do it because we followed a clear scope of practice using single surgeries. However, it's more complicated around open plan clinics. And clearly the three things identified as being problematic are fast handpieces, using a 3-in-1, both air and water at the same time, and of course things like a cabochon, which have been proven to do aerosols and aerosol type procedures. In terms of PPE, we've very much emphasised using reusable where possible. We can see 2 types of masks here, which we're purchasing for the students, and they will be fit checked, these masks. The advantage of using these type is once they're fit checked for good, and it means that if you change the type of PPE, you don't have to refit check them, as you would do with disposable PPE if you can't procure the same sort of material or masks. In terms of open plan clinics, it's been challenging, and therefore we're looking to procedures that only create splatter. For example, changing a fast handpiece for micromotors, using conventional slow handpieces, surgical handpieces, and using the 3-in-1 separately, so air only or water only. We've also looked at procedures, for example, periodontology, in which case we can hand scale only. The evidence tells us that hand scaling can be equally as effective as using a cabochon, and therefore we're moving towards hand scaling only. Around the clinics, we've looked at open plan clinics and airflow and understanding ventilation around the clinics. We're looking at air exchanges and potentially increasing air exchanges, optimizing the direction of air movements, the possible use of air filters, and of course, exploring other options to purify the air, such as virus killers. Also with open plan clinics, we've looked at putting in additional surgeries. So we currently have work going on at clinics to actually surgerize one part of the clinic. So therefore, on the left-hand side of this picture, you can do non-aerosol generating procedures. If you wish to do an aerosol generating procedure, you go into a pod on the right-hand side, which is sealed, and again, the student can then proceed onwards and do an aerosol generating procedure. We've looked at bay zoning and the distance that the aerosol can travel, and the idea of then strategically placing the students in the clinic to actually make sure they're kept safe and the patients are kept safe. We've also explored and looking at additional partitioning and advanced partitioning among some of the bays on the clinic as well. In terms of building access, we've done clear movements of patients and mapped them around the building, movements of staff and movements of the students. We're looking at staggering patients' appointments and actually moving throughout the whole entire day. We're exploring the possibilities of doing clinics in the evening, along with staggered lunch hours. And again, this will be monitored daily to make sure things are kept safe and the movement around the building is appropriate. In terms of simulation, we're upgrading our simulation. While I accept the simulation will not replace clinical experience, we can optimize what we can do with simulation. For example, the use of extracted teeth and practicing root canal treatments. Also, if it's difficult to get a patient in, then the student can now reach for a phantom head, bolt it to the chair, and actually do a procedure there with the supervisor to practice. And again, we're exploring this a lot more. In terms of administration, we've looked at telephone consultations, virtual clinics from a distance held by iPhones or apps, and we're looking at the gradual restoration of clinical services, building both competence with the students and with the patients. And finally, as I said from the beginning, we're doing significant research. This is our Director of Clinical Dentistry here, Ewan McCall, who's on the clinic looking at aerosol generating procedures, looking at how the aerosols spread, and looking at how we can mitigate the spread of aerosols around the clinic. Thank you for inviting me to speak. I look forward to taking questions later.
I would now like to introduce Professor Alistair Sloan, who is head of the Melbourne Dental School, Melbourne, Australia, and Professor of Tissue Engineering and Dental Biology.
Well, good afternoon, everybody, and thank you very much indeed to the Royal College of Surgeons here in Ireland and the Faculty of Dentistry for the invitation to talk to you here from Melbourne, down under in Australia, where, as I'm sure you'll have heard by now, Melbourne is back into another 6-week lockdown due to a recent spike of COVID-19 cases. But that hasn't derailed us, and actually, when I talk about our return to clinical and preclinical activity, I can tell you that at present, we do have students in clinic in both the hospital and the Melbourne Dental Clinic and in pre-clinics as we return to activity. Now, the background to this is on March 23rd of this year, like a lot of universities around the world, we were taken away from face-to-face teaching and went into a virtual campus that was led by the Vice Chancellor. And in a 2-week period, we moved all our teaching online. And that meant we brought all our didactic teaching to an online platform. We actually brought a lot of case studies and a new way of blended teaching for the school to an online platform in a very short space of time. And the Australian Dental Association, the ADA, raised restrictions to level 3. So dentistry really was put into hibernation apart from emergency care. But as soon as we left the confines of the hospital, I immediately asked my colleagues and my staff and my new staff, because I'd only been in Melbourne for about 7 weeks, to start thinking about our re-entry, because I wanted our return to be organised. We left in a mass rush, we left in a state of chaos, and I didn't want that same chaos to be seen as we came back to practice. So our re-entry plan started within days of actually leaving the clinic and teaching online. And working with colleagues in the School of Medicine and ironically the School of Vet Sciences who had similar problems to us, we embarked on a program to deliver a document to the university based around some key general principles. And they were really, at a school and faculty, aiming to reintroduce student placements as soon as was practical, as soon as was safe, and more importantly, as soon as was appropriate. We were planning ahead. We were working with students that were closest to graduation or those that were most impacted by placement interruption, and they were given the initial priority in our plans. And all the placements had to comply with the prevailing national, state, and local clinical regulations or clinic regulations and the guidelines. So social distancing, spacing, prioritization, and availability of PPE. And we had similar parallel approaches to reintroduction of placements that we considered. Simulation of workplace activities. So a reintroduction of preclinical phantom head lab work for our more senior students, restructuring our course effectively, other timetabling rearrangements, so bring all our didactic teaching as much as possible to the front of the year, so that when we return to practice, we had activity up front. And also bringing in new competency-based assessments to determine the level of student entrustability in the workplace. The strategy was very clear. We brought our DCD, our Doctor of Clinical Dentistry postgrads, back first. They were registered practitioners. Our DDS4 and our Bachelor of Oral Health students, our therapists, back at the next level. And then we went back sequentially for DDS3, DDS2, and DDS1. We produced a working document that the students had to work through. And there was a phased and very much controlled return. So our students returned to simulation for a 2-week intensive skills course. It was not just upskill them, having been out of clinic for some part of 3 months, but also to teach them new cross-infection protocols, new PPE protocols, so how to wear scrubs and gowns, surgical masks, FPP2 or FPP3 masks, eyewear and clinical footwear. And we set an exit OSCE that we were then very clear we understood and the students understood what was required of them. Preparation really included measurement of our simulation lab and clinics to ensure we had clear social distancing. And we worked very closely with our placement providers, the Dental Health Services Victoria in Australia and the Melbourne Dental Clinic, and followed directly their health and safety guidance. And the documents were presented to the university, and the pandemic response group that we had signed those off. Now, the actual planning took about 2 months because we carefully managed from documents that we had of plans, the careful management of our space. And in the preclinical environment, in our simulation lab, we zoned this area into zone A, B, and C. And students, as they came in, were allocated to a zone, and space was carefully measured. Temperature of each student was taken upon arrival. There was hand sanitizer at every entry to the building and the lab space and around the chairs. And PPE was worn at all times when students were in this environment. They only came in when timetabled, and the handbook and video was made available for the students. And I can make the video available to delegates as you wish if anyone contacts me in the future. The document itself was really a preparation document that every student had to sign off on that they had read. It was detailed regarding the space requirements, the PPE requirements, with clear instructions on how to wear PPE. And as you can see, we space the students out, and students and demonstrators wear full PPE for the exact time they are in the building. And the clinical environments were slightly different. Again, we had clinical restrictions. The ADA lifted restrictions down to level 1, so we could actually undertake aerosol generating procedures. But PPE is worn throughout the entire clinical environment. And students, when they come into clinic now, no longer leave their bay. Once they're on clinic to see their patient, they stay in that bay. And it's a dental assistant that will run to go and collect the patient from the waiting room to bring the patient to the student. And the dental assistant will go and find the demonstrator or the tutor and bring that person to the student should they need advice and various parts of procedures checking. It's a large polyclinic that we work in, and only half the hospital clinic, so 34 chairs are being used, so we could space out very carefully. In the Melbourne Dental Clinic, it's more of a private practice environment, so clinics are in hubs and are not open plan. And the students stay in those bays and hubs, as I've just mentioned. And we extended our working day to 3 sessions a day, including a Saturday morning at the private clinic, so students could build up that time that has been lost. Now, we can manage aerosol generating procedures. We can undertake processes and procedures that do generate aerosols, but it must be under a rubber dam. And the hospital is looking at a range of different suction units and additional suction units that you can see on the slide here to create a more safer and better environment for our students. But this is a constantly moving piece, as we're currently witnessing here in Australia with the rise of this second spike and a further lockdown. We review all our clinical environments and working spaces throughout every single day. We deep clean every single evening. And we now have created a new division of dental education and innovation, and I've appointed a senior academic to lead a blended learning approach. So there's still a significant amount of online teaching that we have. We're still looking at managing our aerosol generating procedures. They are still being undertaken under the restrictions of level 1, so rubber dam becomes mandatory for us. But the clear thing we're thinking about now is managing this piece, the staff-student mental health burnout. We're very concerned about that. It's challenging for all, staff and student, to understand what is the new normal. A lot of my colleagues still hanker for the old normal of the same timetabling plans. The new division of dental education innovation is to lead this blending learning approach and to develop new ways of online assessment so that we can be more efficient in our assessment. As I say, our students stay in bays or clinics, and we have a new way of working, of bringing the patient to the student or the supervisor to the student. It's a challenging environment, but we now have student activity again, both in the hospital, and our rural placement providers are also now accepting our students back. But the advice I would give is that it's a constantly changing environment, and we have to keep thinking about how we adapt on a regular rolling basis. With that, thank you very much indeed, and I look forward to any questions.
I would now like to introduce Professor Corrado Paganelli, who is Dean at the Dental School of the University of Brescia, Chair of the Forum of European Deans and Heads of Departments, and past President of the Association for Dental Education in Europe.
Hello, I'm Corrado Paganelli from the University of Brescia, and I would like to thank Chris, Albert, and the Royal College of Surgeons for this invitation. I'm going to talk on the Italian perspective on restarting dental schools. I'm the chair of the Forum of European Deans and Heads of Departments and the past president of the Association for Dental Education in Europe, actually the Dean of the Dental School at the University of Brescia, Italy. As you might know, WHO has published a recent paper on Italy showing clearly when everything started as a first outbreak in Europe, with the first cases nearby Brescia, when we reached the peak, and how this is going smoothly down as number of deaths. In comparison of death number in Italy, you can clearly see how the north part of Italy was really affected, while the comparison between 2019 and 2020 in the south part of Italy shows no difference. As for dental situation, I would like to clearly outline the fact that neither the General Dental Council or the Dentist Association had to stop clinical activity, but both asked ethically to reduce providing any clinical activity that was not a dental emergency. But there was no law imposing to shut down dental practice. In further, the donation of PPE to hospitals and the voluntary work to filter and provide information reduced the ability of dentists to provide dental practice service. Despite this, 16 dentists died, but none of them for dental activity. Hospitals were required to reduce activity to undeniable treatments. But of course, general emergency departments were overcrowded, so we were asked to manage as a dental school the emergency in order to avoid patients to go in places that were at risk. So we started the reduction of postgraduate students since 21st of February. Already all the undergraduate were away of the school, and we kept only senior staff on duty. Youngsters had more social life, and with a low income, they had to work in different dental practices, so meeting more people. Further, the Erasmus students were invited to go back home. Our dental school is providing emergency service to the community. We constantly received PPE without any problem. And I have to thank the general administration of the hospital for this. Operators in the emergency area needed relief of pain as they were under stress and concerned about any single pain that might hinder their ability to be selfish and isolated. On the other side, lay people were scared and preferred to postpone the treatment. This was constantly monitored by AD, and we conducted different surveys among deans on changes and adaptations of didactics in COVID outbreaks, and of course, the policy and governmental decision, as they are constantly still adapting. And the main survey now is about structural changes that will be needed in the future. Planning to go back to didactics, admission test, final summative assessment is needed. We think that international collaboration between countries is needed. And for sure, we have instruments like this Zoom to hold a webinar. We recently held a mini colloquium for international students and discussed with them the work on the COVID crisis. The future will be a new normal that will be different from before COVID, but we had already clear since many years how technology-enhanced learning can be part of the solution. So in my view, this initiative, and I really thank again Royal College of Surgeons to be active in this, is educating people not only to share this type of environment, but also a quieter way to queue. Believe it or not, this is Italy, and this is an organized queue to access a general store. Thank you very much for your time, and I'm available for all type of questions.
I would now like to introduce Professor Mary McDougall, who is Dean at the Faculty of Dentistry of the University of British Columbia in Canada. Mary is also the former president of the International Association for Dental Research and the American Association for Dental Research.
Thank you, and it's a pleasure to be here in the Back to School Adjusting to COVID-19 Era webinar. My name is Dr. Mary McDougall, and I am going to be sharing the experiences at the University of British Columbia Faculty of Dentistry. Now, in Canada, we have been very fortunate that the COVID-19 cases have flattened, and the cases and deaths are declining at this point. Nationally, there have been just over 100,000 cases with 8,749 deaths. Now, within British Columbia itself, the total cases are much lower, with only 3,028 reported as of yesterday. Hospitalizations are at 17, ICU cases 4 individuals, and deaths in the province number 186. Now, recovery of patients are 2,667, and the rate of the disease is 60 cases per 100,000. Now, on the chart, you can see that the rate of the COVID-19 infection peaked in March and then has tapered off since then. And this shows the rate, as I said, for July. Now, within the Faculty of Dentistry, I've shown our numbers so you have a size estimation of our faculty, staff, and student pool. So we have about 218 DMD students, 98 dental hygiene students, our graduate students number 102, and our faculty cohort is 89 full-time faculty with 422 sessional faculty members and a staff of 126. Now, in mid-March 2020, UBC, in response to the COVID-19 pandemic and the increasing numbers within British Columbia, transitioned to online learning and remote working for all of our faculty and staff. So at that point, the Faculty of Dentistry started navigating a very disruptive environment, hopefully using innovative approaches to overcome the diversity that we were facing. Initially, we called together a rapid response leadership team, and this represented individuals overseeing our clinical facilities, our educational programs, our student and admissions, both in the DMD and dental hygiene program, graduate programs, and our 2 department heads. Now, initially what we did is reached out through the Association of Canadian Dental Faculties to collaborate on looking at the situation of COVID and the closure of our academic programs to mitigate the impact that this would have on our students. We also collaborated with the American Dental Education Association and all the US dental schools. We developed a plan outlining clinical safety operation protocols, and this was following the Ministry of Health guidelines for the dental area. Now, at that time, we also started resumption of research which was halted with the faculty working remotely. These plans were developed through the Central University COVID Safety Committee, and also working under the guidelines of the Ministry of Health and WorkSafe BC. Finally, then, we transitioned to our educational resumption plans. And this initially involved bringing students back through simulation exercises, followed by ultimately patient care. Now, the phased approach we used to resumption saw that our facilities were never fully closed down. So we did operate an emergency clinic for our patients, and this was facilitated by our faculty members who were volunteers, as well as our GPR residents. Now, initially, the class of 2020, both for our DMD and dental hygiene programs, were our priority in the completion of their competencies so that they would be able to graduate the entire class on time. So by utilizing techniques to bring back our students for competencies and to document competencies of some of our DMD students, this really developed the rationale for further protocols and expanding the number of students that would able to resume their programs. So in June, the Ministry of Health, under a phase 1, opened dentistry. And so we were able then to resume our clinics, initially for our graduate students. We also at that time were able to resume our research activities with a capacity of about 33%. Now in August, we are going to bring back a cohort of our DMD and dental hygiene students from years 1, 2, and 3. And they will come in through simulation to finish their competencies for the 2019-20 academic year. They then will be assessed for promotion. And if they are successful, they will then begin the next year of their academic programs in fall, beginning September 8th. And that education model is going to be a blended one. So all of our didactic courses are going to be online, and simulation experiences will be face-to-face on our campus. We will then transition the students to patient care, learning from the experiences we've had with our graduate programs. Now, what we find in this process, it is absolutely essential to have support, not only for our students, but also for our faculty members. What we found through town hall experiences is students have some challenges with online learning. There have been issues with computer resources and internet signals. And our students are really experience significant financial hardships based on the loss of some of their employment over the summer. And this has really drained their mindfulness, causing stress and anxiety. Communication has been critical to inform the students of the situation on campus and to engage them in the process. So these same critical areas we find also in our faculty. The online transition is harder for some of our faculty. We've developed assistant programs for the transition and learning about online instruction. Computer resources for our faculty. We've moved office computers to their homes and looked into internet signaling and the availability of accessing their computers in their office. Again, mindfulness is critical. There's a number of stresses with faculty. All of their family members are also working home. The schools in Vancouver were closed. So there were issues of having children and having to educate children as well. So we really wanted to facilitate that. And I must say the University of British Columbia has been exceptional in providing resources for people to deal with the global pandemic. Again, communications, we've implemented town halls to keep people informed and address questions that they have. One of the critical components we started is the Sweet Student Fund to provide some support for students in the financial need area. But I'm happy to say the federal government has provided support during the COVID-19 crisis to students to facilitate their basic needs. Now, also, there are a number of challenges that we're facing that are common to all faculties of dentistry. We have restrictions in British Columbia limiting the gathering size of individuals. That is currently set at 50 by the Ministry of Health. In addition, PPE initially was an issue because the mandates of the Ministry of Health initially for providing care was N95 masks, and we didn't have those available in dentistry and had to reach out to the hospital and the Faculty of Medicine to fit our volunteer faculty members to provide care. In addition, you can see on the picture on the left, like many dental schools, we have an open environment in our operatories. So defining spaces for the limitation of gathering size was critical. We worked together with the university as well as risk management and WorkSafe BC to define those. Clinical configuration is open operatories. So we did do an analysis of our airflow, and we were fortunate that the guidelines provided in British Columbia did not mandate, as dentistry opened, closed operatories for care. And then finally, as I mentioned, people. So as we were able to open up our clinic, there was a level of fear and anxiety to return to the workplace. And so we did try to facilitate that through accommodations for our students and faculty members. So with that, I'm sure many of these challenges are shared across many faculties of dentistry, but our take-home lessons have been collaboration, working together, not only within our faculty, but the university at large, as well as other dental schools in Canada and North America. And then also working to mitigate some of the adversities that our faculty, staff, and students are feeling, and to really exude a level of kindness to one another. And the Minister of Health, Dr. Bonnie Henry, has been very vocal about being safe and being kind to one another during this pandemic. So that is a great lesson for all of us. Thank you.
I would now like to introduce Professor Mark Latta, who is Dean at Crichton University School of Dentistry and Professor of General Dentistry at Crichton.
Hello, I'm honored and truly humbled to be a part of this wonderful group of dental professionals around the world discussing how dental education is responding to the COVID-19 pandemic crisis. The title of my presentation is Back to School, the COVID-19 Response as it relates to Creighton University School of Dentistry in Omaha, Nebraska. I'm Mark Latta, and I serve as the Dean, and I'm a professor at the School of Dentistry. The response in the United States to the COVID-19 crisis is very regional. The United States did not publish standard guidelines for all 67 dental education programs. And in fact, health directives mandated by each of the 50 states dictated how each community and state, and thus each dental school, were asked to respond to the crisis. On this map, you can see a distribution of the public, private, and state-related dental schools currently in the United States. Creighton University School of Dentistry, located in Omaha, Nebraska, is located almost in the geographic center of the lower 48 of the US. We've been extremely fortunate being in the state of Nebraska, which has not faced the same rise in cases for COVID-19 infections as our country has seen in large regions, primarily located in the Northeast, in the New York area, in the Southwest, in California and Arizona, and in Florida. In March, many of the states generated health directives mandating that only urgent dental care would be provided by dental schools and dental practices. In May, many states began reopening to provide both comprehensive and elective dental care. But as we've come into the month of July, the United States has seen significant increases again in states like California, Nevada, Arizona, Texas, and Florida. 14 states have been identified by the states of New York, New Jersey, and Connecticut as requiring visitors from those states to those 3 states to self-quarantine for 14 days. So the landscape for COVID-19 in the United States is still rapidly changing, even in July of 2020. Now, on March 16th, in the US, the American Dental Association proposed guidelines that postponed all elective dental procedures and that only urgent or emergency care should be provided by dental practices. At the same time, hospitals and medical centers put the same restrictions, providing only urgent care for patients presenting to those tertiary care centers, and elective surgeries were not allowed. These national guidelines were extended to at least April 30th by the American Dental Association. But in many jurisdictions, particularly in the South, West, and Northeast, these health directives extended beyond April 30th. And those extensions depended on the specific state health directives. For Creighton, located in Nebraska, we were able to return at our dental school to comprehensive care at about a 40% capacity beginning on May 11th, as we welcome back our 4th-year dental students who were trying to complete their completed years of study to graduate. Now, the economic impact on dental practice in the country has been quite significant. It's projected to lose 38% of the original projections of $148 billion of dental spending in the calendar year of 2020. The American Dental Association's Health Policy Institute has projected that assuming an 80% recovery, there'll be a reduction of 19% in dental spending in 2021. But the surge in dental cases right now has caused some estimates to make the 2020 and 2021 dental spending even more dire for dental practices. Now, this recent article in the Journal of Dental Education described mostly the teaching and learning impact of COVID-19. On March 16th in the United States, all US universities essentially went to online teaching pedagogy. Now, of course, in dental education, simulation learning and clinical care could not be done in a virtual or online environment. This move to online pedagogy created an asynchronous teaching module and a high use of learning management systems such as Canvas or EdPuzzle, and new assessment tools being employed such as ExamSoft, which were employed to use third-party proctoring of typically synchronous teaching. As we move back, and this slide reveals an empty classroom, of course, as we move back into the classroom, the social distancing mandates required for in-person teaching really created hybrid models of pedagogy so that problem-based learning would be done in smaller groups, while there's still a significant platform for didactic classes to be delivered asynchronously in an online module. For assessments, there was a significant increase in the use of OSCE-type examinations, as well as mannequin simulations. As we returned to the classroom, we were only allowed to have 50% of the students that would normally be seated in this particular 60-person module. As we reopened in our school, every day, all patients, faculty, staff, and students are screened. Their temperature is taken, and specific questions are asked regarding their potential contact with COVID-19 positive patients, and as well as whether they have symptoms. Patients are required to enter the building, as well as faculty, staff, and students, wearing personal protective equipment, in particular masks. Social distancing is employed in all of our areas, in the waiting room, in classrooms, and in student gathering areas. As you see in the lower left-hand corner, even our staff, in this case, our financial staff, wear protective masks and also employ protective barriers to prevent contact with our patients as they move in and out of our clinical setting. We will employ mandatory testing for any student, staff, or faculty member that has symptomology, and they can only return if they have a positive COVID test once they have tested negative. And we use contact tracing, that is contact that the faculty, staff, and students have had, to trace backwards how they may have been created into having a positive COVID-19 test. In our preclinical simulation area, we have a laboratory that you can see revealed here in pods of 4 in a pinwheel design. This space holds 120 students. The health directives of the state of Nebraska require that we only put 50% of the capacity in this space. This means that we can only at one time have 2 students in a pod, and it means we have to divide our cohort of 115 dental students into 2 different flights of classes to create the environment for them to learn in this space. You'll notice in the background the blue separating walls. These are movable walls. What we have created in this space are pods of 20 students at one time. The reason for this is if a student tests positive, we only do contact tracing and test 20 students that were in this pod. As this laboratory has 3 different entry and exit points, these pods of 20 students will enter and exit without mingling with the other students as a way to control and minimize the amount of students that may, if they test positive, be required to be tested or actually leave from the direct in-person educational program. In our clinical environment, when aerosol generating procedures are being performed, we use alternating operatories to minimize the contact of aerosols that might be generated in the operatories to an adjacent operatory. Unlike in the United Kingdom, which mandates a 1-hour furlough from a treatment space, the United States has not operated that way or mandated that kind of a protocol. Whenever an aerosol generating procedure is being done, both N95 high filtration masks and face shields and dental assistants are required in the treatment areas. Moving forward, we will be putting engineering controls for our heating and air conditioning systems in the building where the clinics are circulating air 3 times an hour. The system that we're employing is by Global Plasma Solutions. It is an ultraviolet system that will treat the air from the dental treatment areas in the building HVAC systems 3 times per hour. We are also purchasing portable extraoral dental suction units to maximize the gathering of aerosols when aerosol generating procedures are being performed in the dental operatory. In conclusion, I want to express my appreciation to Professor Lynch and the Royal College of Surgeons in Ireland Faculty of Dentistry for this opportunity to discuss with you Creighton University School of Dentistry's response to the COVID-19 crisis. Thank you.
I would now like to introduce Professor Zaid Bakeen, who is Dean of the Hamdan bin Mohammed College of Dental Medicine and Deputy Vice Chancellor for International Affairs at Mohammed bin Rashid University of Medicine and Health Sciences, Dubai.
Dear colleagues, I would like to thank the Faculty of Dentistry at the Royal College of Surgeons in Ireland for giving me this opportunity. I'm reporting to you from Mohammed bin Rashid University of Medicine and Health Sciences, from the Hamdan bin Mohammed College of Dental Medicine, a postgraduate dental college offering a 3-year MSc programs in several disciplines. Our master's program are clinically intensive. Quickly taking you through the timeline of COVID-19 in Dubai and the United Arab Emirates in relation to clinical training and service and education. So the first case was reported on January 29th. This was followed by a series of directives from the Ministry of Education, bringing forward the spring break and mandating online education till the end of the academic year. And then there was further elaboration on assessment and grading. With regards to service and training, elective surgery was suspended in the UAE on March 18th, to be followed a week later by suspending routine dentistry. Dentistry reopened with restrictions in May 27th. The restrictions included limitations on aerosol generating procedures and mandating the use of PPE. The university, we responded early. We established a task force and we initiated a smart hub that aims at educating faculty and staff on the tools for online education. A mandatory work from home policy was implemented. We updated the business continuity plan and started a scenario planning exercise early in May. Dubai established a COVID-19 command and control center that was led by our Vice Chancellor, and fortunate to us, it was and is still currently based on campus. The UAE had a disinfection program that restricted mobility of people at certain hours of the night. In Dubai, this disinfection program went into a 24-hour cycle from April 4th till April 23rd. Up until July 7th, the UAE reported more than 52,000 cases with very low mortality of less than 1%. However, it's important to mention that the UAE has one of the highest reported testing schemes per capita, with testing happening between 50,000 plus and 70,000 plus a day. As for us in the dental college, once we switched to online education, we also switched our clinics into virtual dental clinics. The virtual dental clinics were semi-structured, small group learning through video conferencing, discussing cases, reviewing literature, and watching instructional videos. This also included multidisciplinary team clinics on occasions and involved inviting colleagues from other programs and other universities, including King's College in London. Also, our postgraduates and faculty were involved in offering teledentistry after a thorough educational program. Interestingly, we had to conduct our multiple mini interviews online And this was a fantastic experience. And we shared our outcome with colleagues in other institutes in the UAE. Our CPD program went online, and we launched MBIU Dentalk, hosting international speakers. Resumption of clinical training was permitted on June 7th. Therefore, we allowed our postgrads to come back in a staggered manner and voluntarily. And this will continue throughout the summer break, giving the opportunity for our postgrads to obtain the missed competencies and to compensate for some of the clinical training sessions missed in the preceding academic year. In addition, I would like to highlight that communication with students was continuous. Our psychologist and counselor was in continuous contact with faculty, staff, and students. We had weekly mindfulness sessions, support groups, cognitive therapy, and even one-to-one sessions. Online summatives with online proctoring went well, and we used different tools to assess both didactic and clinical courses. For the fall semester, the didactic courses will be either online or face-to-face, especially for the small group discussions and specialty core courses. The clinical training, we will expand on clinical training. So we will extend the working day, and we will increase the number of working days per week. This will allow for us to bring back our postgrads and maintain physical distancing, reduce the number of people on site. Add to that, allow us extra session to compensate for the missed clinical training of the preceding year. This will require flexible working hours to maintain the 40 working hours a week for our staff. And for that to be done, we will need the support of part-time faculty, which is secured. With regards to prospective students, we have commenced early communication with prospective students, and we have organized a program for a blended extended orientation week. For prospective and current students, we are looking at increasing the financial aid as we are anticipating some financial hardship for some of our students. With regard to the hospital, we have completed and revised guidelines. We have obtained and procured all the necessary personal protective equipment. We have upgraded with our engineers the ventilation and suction systems. We're looking into procuring more devices and appliances. We have revisited the functional and supporting spaces, increasing the number of rooms for changing and donning and doving. And we are considering regular testing for our students and staff in the fall semester. We have looked at research to mitigate any potential risks for ongoing clinical research for both our postgrads and staff. And with regards to recruitment, everything is going according to plan, and we have no problem with retaining faculty and staff. This is the revised guidelines. It's a comprehensive document with links to recent literature and international guidelines. And this is an online course that everybody that has to come back to Dubai Dental Hospital, our training facility, has to successfully complete. And now it's open to colleagues outside the university and outside the country. Once successfully completed, a CPD certificate is issued. Finally, and importantly, we have identified some gaps, but more importantly, we have learned new lessons. We are capturing a lot of data, and now we are analyzing data on the perception, experience, and resilience of both our postgrads and faculty. Also, we have identified that in dental education, we still need to work on smart learning and teaching. And we ask ourselves a big questions. Are we prepared for future crises? Are we prepared financially? Are we prepared to face future pandemics? And I hope we can discuss this further today. Importantly, we learned important lessons. We have newer educational ventures that allow us, for example, if we incorporate more online courses for our postgrads will have more time for clinical training and scholarly activities. Technology is important. Teledentistry, haptics, augmented and virtual reality are things to be explored more in the future. Interprofessional education. We have realized that we need even more convergence with our colleagues in medicine in areas like infectious diseases, community and public health. Global networking and international collaboration. It's much easier and it's much cheaper with online collaboration, and it's something that we would like to expand on in the future. Finally, His Highness Sheikh Mohammed bin Rashid, UAE Vice President and Prime Minister and ruler of Dubai, stated early in the crisis that healthcare is the main power that shapes economy and politics at a time when a disease has brought nations to a standstill. We believe that we are preparing future dentists to be essential healthcare workers. Thank you very much.
I would now like to introduce Dr. Christine McCreary, who is Dean and Head of School at the Cork University Dental School and Hospital in Ireland.
Hello everybody, it's lovely to talk to you all today. I'm very grateful for the invitation from the Faculty of the College of Surgeons in Ireland for this invitation to participate in this webinar. I have a long association with the college and I'm delighted to be here today to speak to you. So I'm going to talk a little bit about the context of COVID-19 in the Irish situation, and then a little bit about how our own dental school here in Cork has responded to that. So this country went into lockdown in the middle of March with an announcement from our Prime Minister or Taoiseach, Dr. Leo Varadkar, who you will see on the left of this slide. He was in America at the time for the St. Patrick's Day celebrations when he came out and made the first call that things were serious and things would have to stop. Ireland has come out of this pandemic a lot better than many countries, but not as good as some. We certainly are in a much better position than our nearest neighbour in the UK. As I speak to you today, we have over 25,000 confirmed cases and over 1,700 deaths. COVID struck in Ireland in a health system which was really under a lot of strain already. We took advice from NEFIT, our National Public Health Emergency Team, led by our Chief Medical Officer, who really did do a very good job of shepherding us through the pandemic. For us here in Ireland, there were a few very topical and buzz kind of items that came at us. Skiing holidays, that seems to be where the first infected carriers came back from skiing in northern Italy and caused infections. The Cheltenham Horse Racing Festival was allowed to go ahead, and there was a lot of cross-contamination from people travelling over and back to the UK. The Ireland-Italy rugby match, although it was cancelled, a lot of Italians travelled to Dublin. And then later on, as the pandemic evolved, we had a serious problem with a number of high cases in nursing homes and also in certain meat factories in the country. And in fact, over half the people who died in our nursing homes. In terms of our own response, well, we work here with both an educational function as a dental school, but also as a dental hospital. So our dental hospital remained open throughout the pandemic, running emergency dental clinics, because all of the general dental practitioners in the city, in fact in the country, did not continue to work. Patients were told to stay at home. They were concerned about the aerosol generation involved in dentistry, and so they did not function. In this building, as well as our dental emergency clinic, we also accommodated some general medical outpatients from the co-located general hospital who were moved out because of COVID. And we engaged in research, particularly in aerosol generating procedures. In terms of our education function, the university closed, the dental school closed, all our students were sent home. And very, very quickly, all of our educational tools became online. And that was the reality that we have dealt with since that day and continue to deal with today. We went immediately to online delivery of tutorials and lectures. Obviously in March, our academic year was only halfway through. We got through all of that, and then we had to start preparing for online assessments. And that caused a lot of stress and hassle for our staff. But I have to say, as a process, it actually passed off relatively smoothly. We even managed to graduate our final year dental class virtually in the middle of June. And immediately following all of the end of the examinations, then our minds turned to preparing for the next academic year. And those preparations go on today. I should let you know that in Cork, the dental school feeds through the College of Medicine and Health up to the Central University. That can have challenges in that we don't have, if you like, a direct seat at the main table, and convincing Central University, dealing with all of the disciplines and all of the subjects that any university deals with, that dentistry is slightly different and needs a slightly different approach can be difficult, and it proved so under these conditions. We also have a very large international cohort, so we were worried about their welfare. We were worried about how they would come back to us. And obviously there are financial considerations for the university with all of these international students. There were 3 principles that the university set out at the beginning: that students should not be academically disadvantaged. The principle of subsidiarity, at least in theory, sounded like a good idea, where Central University would listen to the individual schools who it was felt knew their students and processes best. And in reality, that did prove problematic, as we wanted to do some things that Central University was not happy about. We wanted to take all of the teaching for years 1 to 3 of our course online for the next semester. We've got there, but that did prove problematic. The university generally made this move to pivot towards technologically enhanced learning, and we were delighted with that because that obviously fed in very nicely to what we were doing. For us, it's always been about our students first and foremost. We wanted to make sure that they were safe and well, mentally as well as physically. Obviously for our staff as well, their mental well-being as well as their physical well-being was a priority to us, and our patients who were cut off, if you like, in the middle of different treatment regimes and different treatment plans. We had to obviously consider how we were going to come back in touch with them. So communication has been very important, and it has been at the center of everything that we've tried to do in the intervening weeks and months. But now we are well up in terms of our planning for the next academic year. And just today, we actually signed off on our timetable for the next year. I have referred to the fact that our interactions with the Central University were slightly fraught at times. However, I would have to say that the university has been entirely supportive of all of its student cohorts and its staff. And there's a lot of information available through the different university websites. This is just an example of one of them. And then I suppose I come to nearly my most important slide, and this is probably where you will get most of your questions and most of the issues that concern you. It's hard to think that such a small submicroscopic organism, not capable of independent existence, can cause such havoc and chaos in the world. And for us here in the dental school, these are just some of the issues that we're dealing with on a daily basis, to try and make things safe and functional and efficient for our student cohort, our staff cohort, and our patients in the next academic year. We've had multiple walkthroughs of the building, looking at corridor spacing, looking at rooms, looking at changing rooms, looking at toilets, looking at number of people in the building. We've been looking at our work practices, how we might change, looking at timings, looking at cross-infection control, looking at what PPE equipment we need, looking at where we might carry out aerosol generating procedures. Our clinical governance committee has worked tirelessly to provide us with the clinical evidence and background to make our place of work safe. Social distancing, we still don't have a definitive answer about social distancing. Currently in this country, it is still 2 meters. We're hoping that that will change, but given the new evidence from the WHO, who knows? You can't practice social distancing, obviously, in clinical zones, so we're risk assessing each of those. We are dealing with staff and student concerns and apprehension and questions on a daily basis and trying to maintain the communication channels there. And we're dealing with the patients who increasingly are becoming anxious about what's going to happen in the weeks and months ahead. So I don't have all the answers for you. I can discuss some of the issues that we've dealt with and how we've solved them if you have any questions. But that's really all I have to say. I just want to say thank you for the opportunity to share our experiences with you, and I would be happy to take any questions. Thank you very much.
Ladies and gentlemen, following some splendid presentations that you have heard, welcome to the discussion session of the webinar now that we have, Back to School in the Time of COVID-19 and International Perspective. And with me are the panel members. We have got Professor Chris Tredwin, Dean of the Faculty in the Peninsula Dental School, Dr. Christine McCreary, Dean of the University College Cork Dental School, Professor Mary McDougall, Dean of the University of British Columbia Dental School, Professor Mark Letter, Dean of the Creighton Dental School, Nebraska, USA, Professor Corrado Pecanelli, Dean of the Brescia Dental School and Chair of the Forum of European Dental Deans as well. We've got Professor Saeed Bakane from UAE, and we've got Professor Kung Leung, Professor of Periodontology from University of Hong Kong, Professor Carl Lyons, Professor of Restorative Dentistry, University of Otago, and Professor Alice Leung, Dean of the Faculty of Dentistry, University of Melbourne Dental School. You're very, very welcome here, and I'm very, very grateful to our panel members. And I'm Professor Albert Leung, Dean of the Faculty of Dentistry, Royal College of Surgeons in Ireland. And with me have got Professor Chris Lynch, Vice Dean of the Faculty of Dentistry, Royal College of Surgeons in Ireland. So, Chris, if you could let us know what our first question may be, please. Thank you very much. Thank you.
Thank you very much, Albert. And once again, I would like to thank our excellent panelists for their superb contributions this evening. Quite a number of questions have been coming in, and I'm going to group these thematically to make sure that we cover as much ground as we can over the next 40 minutes or so. One popular question, or one common question, which is coming in and surrounds UK dental practice, but is also applicable to other parts of the world, is the requirement for a fallow period following an aerosol generating procedure. I know Professor Tredwin mentioned this in his presentation, so perhaps, Chris, you'd like to begin the discussion on this point and what dentists and dental education are required to adhere to within the UK, and then we'll open up the panel, we'll open up the discussion to some of our international panel. Thank you, Chris.
Thanks, Chris and Albert. So it's a very great topic for conversation in the UK at the moment, because at the moment, after an aerosol generating procedure, we're looking at an hour of fallow time, which is making it quite difficult to do things effectively, both in practice and, of course, in an open plan clinic. So the approach that we've taken initially is looking at the idea of very much in open plan clinics of looking at doing non-aerosol generating procedures as much as possible, which encompasses a lot of dentistry. So in terms of history, examination, special investigations, radiographs, dentures, oral surgery, all stuff that we can do with non-aerosol generating procedures. But in terms of the aerosol generating procedure, I think we are a slight outlier in the UK as well, having listened to other presentations and also what's gone on in the rest of the world. And now it does seem quite an excessive period of time in the UK at the moment. So I welcome to hear the rest of the panelists to how long they're doing for the fallow period after aerosol generating procedure, and very much listen. I think the other thing to make clear is we must be evidence-based. We're all scientists, and I'm not sure sometimes we are following complete evidence where we have it. So again, it'd be very interesting to see what the rest of the panel have to say about the hour fallow period.
Yes, thank you very much, Chris. Corrado in Brescia in Italy, the first epicenter of this outbreak. So how
well,
are you
in Europe, Albert?
Yeah.
Please, not for entire world, but
thank you very much.
Iftia, I have to say that what Chris has already outlined is a matter of concern. So we are really looking forward to a WHO sentence on this, because we have to understand if we are speaking about prevalence of viral particles or we are speaking about aerosol of general dimension. So of course, if we are considering WHO sentence just now in Italy, if you are asking me this part of Europe, what is happening, we are following the 15 minutes time elapse between one patient ended and starting to clean the chair. But this is really a matter of concern. And I think that this experience, despite technical difficulties, is what we have to do. We really have to discuss among ourselves, because as Zed has said before, we don't have evidence, and we are extremely interested in what is the new evidence for this type of activity.
Thank you very much, Corrado. If I could try to come to Mary, possible. Mary, can you hear us? To see what UBC might be working on to do. Thank you very much. Lovely. Thank you.
Thank you. So within British Columbia, we've had a very phased approach. So the initial guidelines were much stricter in the period of fallow before the next patient is treated. And that was an extended period of time. And now we are able to turn over the operatories with a much shorter phase. But that is all dictated by the guidelines through the Ministry of Health and our regulatory agencies, such as the College of Dental Surgeons.
Okay. Yeah. Maybe we move on to a slightly different question. Chris, anything that we will have for the next question? Thank you. Thank you very much.
Absolutely. Thank you, Albert. I think one of the next most common and most interesting question coming in relates to the clinical experience of our students, particularly our incoming final year students and graduating class for 2021. And the question surrounds whether the panel think that our coming final year class or graduating class will experience the same competencies. Do the panel feel that the final year needs to be extended? Have the panel got any innovative strategies for mitigating the current interruption to clinical exposure and experience by many of our students? So maybe if we start with Christine on that point, please.
Okay, thank you, Chris. Yes, we have considered this in quite a lot of detail in Cork, and we have already notified the university that it may be possible that we will be extending our academic year for our final years. So they are coming back a little bit early. Their blended learning part of their course will start on the 4th of August. Normally it would be the end of August. And normally they would qualify, their exams would be finished in May, and they would graduate in June. But we are looking perhaps at extending that into July or possibly August. Of course, it's an evolving situation for everyone. We are maximising their clinical experience because they've already lost a lot of time in their 4th year of clinical experience. So we have to try and make that up. And that has proved challenging, given the infrastructure and resources that we've had to deal with. It's entailed a lot of cooperation and compromise from the different clinical disciplines to arrive at a timetable for our final year class that we think can achieve the objectives required by the regulator and by the university. I think we've got that, but I cannot speak if a second or a third or a fourth wave of COVID strikes. But at present, we are hopefully on course to graduate in August.
Yeah, Alistair, you're raising your hand. Alistair, what about the situation in Melbourne?
Well, of course, down here in Melbourne, we're in the middle of our final year. So our academic year is very different to the Northern Hemisphere. It follows a calendar year. So we've already made the decision that our final years will be extended for about 6 to 8 weeks. So they will, rather than graduating in December when they should do, we're extending them into January. For their exams will be at the end of January, start of February, and they'll graduate in February. That gives us a sort of 6 to 8 week period to build up the lost time that they've had for the sort of 2 to 3 months they've been out. The university has been very supportive for us in that respect. And I have to say, as somebody new to Australia and new to Melbourne. I've only been in the role here in Melbourne for 6 months. Is that the actual regulator have been very, very supportive of all dental schools down here in Australia, and regular conversation with our regulator has been very, very helpful to allow us to get a cohesive view on how we will manage our final years. And it looks like certainly in Australia, a number of schools may be extending, but we certainly are here in Melbourne to give those students the very best experience they can. I'm very aware and very clear that I don't want this cohort to be known as the COVID cohort. And that also extends to us looking at opportunities for postgraduate based mentoring programs for our graduating years. So we don't just let them graduate and go off into practice. We actually keep in contact with them and support them for the first part of their professional careers as well.
Thank you very much. And how about in the situation of Hong Kong then, Kong? Would it be affected? Would the curriculum be extended? Or how is the Hong Kong University going to deal with it if there's another outbreak coming in?
Thank you, Albert. Actually, as a matter of fact, we are having increasing cases as we speak now in Hong Kong. We're worrying quite a lot about it. While in the start of the crisis, when we had sometimes off from the school, which stopped for a while, the faculty has been busy looking into this. So a few of us have been looking at the log of the graduating class, the current 5th year, we have 6-year curriculum, the next year to graduate, and we're logging the amount of clinical education they can have. Luckily, we are in a competence-based education, so we are checking the student whether they are able to achieve the competence at the time. We expecting delay, honestly, and the university somehow help us through the government to secure more funding. We've been talking to the Dental Council of Hong Kong, and then for the graduating year this year, that we are negotiating about the level, calibrating the level that we want, and so on and so forth. That class is not that bad, but the next class to graduate is our worry. And we had funds set aside, and then our dean had given us money to recruit more hands so that we can get the student. Once we started, actually we're starting, but we are under the shadow of the second wave of the infection now. So, but we have decided, we just have a meeting this evening, we have decided to move on cautiously because we believe that the COVID has to stay. So we are working on that, and then there's all preparation about this, and we have regular discussion with the student, and they understand perhaps they might have extended class. So as we speak, we didn't have a fixed date yet, but we understand we have to work a bit harder.
Thank you very much. Syed Bakay, in your case there, where you are training postgraduates, would that affect you similar way as undergraduate, or are they very, very different in your particular situation in your school?
Well, I think it's we're in a different position having postgrads only, but I think the challenge is the same. But I think two key words, I agree with Alistair and Christine, it's an evolving situation, so we need to monitor and we need to keep communication with the regulator. In our case, it's the Commission of Academic Accreditation. However, what we have done is that we have increased the number of clinics for the fall, and including also clinics during the summer break now. And also we have increased sort of a training week. Instead of being a 5-day a week, making it 6-day a week. However, we had to rely, and of course the university was supportive, on part-time faculty supporting these additional clinics, allowing our postgrads to compensate and acquire some of the missed competencies. However, if there's another interruption in the future, then we're gonna sort of maybe make new decisions, and extension could be on the menu.
Okay. I mean, I was just wondering whether you may alter the assessment criteria, alter the way how examination go, assessment and competency. May that have an effect as a result of these changes? If we can try to go back to Mark.
Well, in the United States, the licensing of our graduates is a patchwork across the different regions and states. And our accrediting body, the Commission on Dental Accreditation, while for the class of 2020, they've given all the dental schools some latitude in assessing competence as suitability for graduation using alternatives than what we normally would have done. They have not established yet guidelines for 2021, and it's a very active area of discussion right now in the U.S. But even though we were able to graduate our students perhaps 6 weeks late in our cycle of the cohort of 2020, the licensing examining boards, which are regionally based, not state-based, postponed their examinations because, as many of you know, many of our states require patient-based assessments as one of the conditions for licensure locally in a given state. And so these examinations, typically given in February, March, and April, were all postponed into August. So while our students have graduated in May and perhaps June, they can't sit for their licensing examinations now until deep into the fall. So it's created a bit of chaos in terms of entry-level licensing in the United States. So all of us in the U.S. are waiting with some bated breath as to see what's going to happen next year for this class of 2021. It's a lot of uncertainty right now.
Yeah, thank you. This is an uncertainty that we have to live with for a very long time to come. Chris, if I could come back to you, what is our next questions from the audience? Thank you very much.
Sure. Thank you, Albert. And again, a big thank you to our panelists who are doing fantastic tonight. One of the next questions comes back to something that's very close to my own heart. I'm a professor of restorative dentistry, and quite a number of questions are coming in about how we manage open plan and polyclinic situation where we would have many students operating at the same time and a supervisor wandering around supervising students in that situation. So I suppose the question is, how are different schools planning to manage that scenario? I might come to Mary first with that question, please. Thank you, Mary.
Thank you, Chris. So in Vancouver at the University of British Columbia, we do have large open format clinics. And fortunately, we've worked with our risk management team as well as the Ministry of Health to determine the number of students and faculty that can work in the area. So from that context, we believe that our
because I dropped off
wearing PPE for simulation exercises. That's part of our normal protocols, so that social distancing or the physical distancing that's required by our Ministry of Health will be fulfilled under those circumstances. So we are able to conduct treatment in the open air clinics. Thank you.
Thank you very much, Mary. Good answer. How about in situation in Peninsula Dental School then, Chris? How would you manage the same situation with that?
Absolutely. So we're looking at, as you heard in my presentation, the idea of having kind of little hubs and actually partitioning on parts of the clinic. So actually you can go into a little room and do an aerosol generating procedure. We're looking at the distances between the chairs and the amount of spread of the aerosol around the clinic environment itself. And also looking at staggering the clinical day as well. So lots of ways of looking at it. First of all, about the spread and trying to mitigate the spread, but also the idea then of actual individual rooms that the students can go into to actually do the aerosol generating procedure. So again, very optimistic about the way forward and the possibilities open to us. And I really think that in terms of going back to the previous question as well, is that I think we know a lot more by Christmas, and I think Christmas will be a key time for everybody because we know exactly what's happened with the virus and how things have been determined from there. But again, as everyone knows in the room, there's a lot can happen in a dental school in one day, let alone in a year. So it's a very dynamic environment, and when things have to happen, they happen very quickly. So I'm really positive that the team that we have in our schools and the team we have around us will get the group of students through, will maintain the standards of those students, and we'll have a very successful year ahead of us. But there will be challenges every day, but I'm sure that we can all work together as teams and overcome them.
Thank you very much, Chris. Alistair, you might have some comments about this, about the Melbourne situation.
So we're currently practicing to a very small degree. We got our students back in a staggered way, as I mentioned in my presentation, coming through the simulation lab. They're due into clinics and into practice next week. We, of course, have a second spike, so it's a very interesting time for us to see how we can manage this at this point in time. But like my colleagues, we have basically social distanced in our big open plan polyclinic. We're using half the clinic space, but we're keeping the student in the bay. So actually keeping the student where they are rather than the student moving around has been the best thing that we've been doing, working with our colleagues in Dental Health Services Victoria. So the dental assistant will go and collect the patient. They'll go and collect the supervisor, but the student stays put in the bay. So we try and minimize movement around the clinic, as well as try to generate generating procedures and aerosols that will come from that as well.
Yeah, thank you very much. Christine, any comments on this? How you might manage in Cork?
Yeah, I think our situation is perhaps slightly different. We have a relatively old building that is not particularly fit for purpose, in that we have a lot more students now than we had when it was designed. We have looked at our closed surgeries with ventilation and used those for our AGPs, but we're supplementing that with the provision of like Perspex kind of pods that are completely sealed, and those will be used for AGPs also. We're also looking very closely at extra suction, extra-oral suctions, high volume suction. And preliminary results would suggest that that's a very useful way of minimizing aerosol spread. So I think it's a combination of methods. And as Chris said, by Christmas, we will have a lot more experience of what we're dealing with, and perhaps a lot more knowledge, which is evidence-based.
Yeah, thank you very much. Completely agree. I think it is important to know that it's a combination of approach of air change or putting physical barrier, Perspex, and in different practices, like the nurses go and fetch the patient, like Alistair's experience in Melbourne, or other means like Chris Stradwin in Plymouth, Peninsula Dental School, all combination of which there is the combination in the flexibility. I think that is important because we're facing a lot of uncertainty indeed over the next few months and year ahead. Christine, so you'd like to say something?
Albert, in relation to the polyclinic scenario, we are in the process of designing a new building at the minute. And we have designed a polyclinic in. Now, we had that done before the advent of the COVID pandemic. However, I cannot really imagine dental undergraduate education in another environment apart from a polyclinic. So I think our polyclinics will continue, but they'll have to be designed in a way that they can be pandemic proofed or virus proofed, or that we have protocols and procedures in place to deal with that, because I don't think you can educate students in individual surgeries, really.
No, that's right. Very, very specific use. Chris Stradwin.
Just a brief one, just to put it out there, really, is that I really believe that we control the aerosols we generate, because most chairs that we have a water bottle in it. And I think there's definitely some research to be done as to what we could potentially put into our water bottles to actually cause harm to the virus in the environment we're in and not harm to the patient. And I kind of put it out there to everyone here in the room and listening, is to think about what we might be able to do there and what aerosols we could generate would help us in the direction of controlling the spread of the virus.
Yeah, and also very much the speed increasing handpieces, reduction of chip air, and use of high volume suctions and things there as well. I think very, very important subject to discuss. Chris, would you like to please show us what our next question is, please? Thank you.
Sure. Thank you very much, Albert. There are a number of questions coming in about testing of patients and students and supervisors on clinic. And I think there's a lot of anxiety amongst some of the question writers in relation to this. So I wonder if we could discuss that for a few minutes, please. Mark, would you have anything to provide? Because I know you've touched on testing of patients and students within your dental school.
There's some very interesting things being done in the U.S., and then I'll tell what we're doing at Creighton. The University of Utah, for example, tests every patient with PCR before coming in, and what they found is 2.5% of their patients coming in are asymptomatic carriers. Generally, most dental schools are deferring elective care for anybody that has symptoms until they're tested to be not infectious at this point. The Centers for Disease Control in the United States recommends either a symptom-based or a test-based protocol for determining when a caregiver can, once positive, can return. The system-based or the symptom-based one is obviously determined when someone who is symptomatic is tested and is confirmed to be a positive carrier. And then based on the current understanding of the disease, because people can test positive and be shedding virus that's not activated. And so the ambiguity around whether or not a negative test one way or another actually shows, or whether a positive test actually is misleading someone, which is why the symptomatic component is now being more widely adopted. From the onset of symptoms, a 14-day quarantine, 72 hours of no symptoms, and fever being afebrile without antipyretics. And in most situations with personal protective equipment, these healthcare providers are being allowed, our students are being allowed to come back into clinic.
Thank you very much. I mean, testing is very, very important, of course. Carl, can we come to you to see whether we can hear if you've got any views from Otago?
So at Otago, we have a screening test. So we have a phone triage for all patients prior to confirming an appointment that we then reconfirm with a series of epidemiological questions to check whether any of the patients have any symptoms of COVID. Because we have no community spread in New Zealand at the moment, we have positive cases, but they're all in managed quarantine. It's our Ministry of Health consider that the risk to the community, to us, is very low if patients are answering negative to the epidemiological tests. And so we're really quite fortunate in the situation that we're in at the moment, that we are able to carry out full range of dentistry really pretty close to how it was before COVID.
You're in a very, very luxurious position that New Zealand is in. I think that's probably why your Prime Minister is so popular coming into an election, perhaps. But it's a very marvelous job with the well-contained cases that you have. How about the situation in Hong Kong then, Kung? How are you dealing with testing students? Or
Well, thanks, Albert. We started testing the students and the staff for around 2 months. I think the idea is to make sure everyone is safe, and then also let the patients that the student take care of knows that we are okay. And so far, I've been tested a few times already myself. And then we had a meeting today, and we had a report, and there's so far no positive detection can be found amongst ourselves. So perhaps because still that low infection rate in Hong Kong, we haven't get into testing the patient for the time being, because we are using the university faculty money, so it's a little bit politics there. So might be in the long run we go into that, and because Mark is correct that possibly a few asymptomatic one persons they might have test positive. So this is so far the situation in Hong Kong.
Thank you very much. Thank you. Corrado, what about the situation in Brescia?
Well, of course, I'm not in the situation as Carl. I'm not so lucky, of course. But I would like to point out the fact that we are speaking about increasing the number of part-time teachers. Because definitely to go for what Christine said about blended learning, we definitely need a higher number of teachers, and maybe we have to take advantage of what is the availability of part-time teachers. And in our case, I have to admit that we have tested immediately our staff for the first outbreak, and we decided to use only senior staff in the dental school in order to keep youngsters that have easier social life than senior staff, and thus could spread the contact about social life. So we decided to keep the school in a safe environment at the beginning, and now, of course, we are opening what was closed to higher involvement of part-time teachers to be tested again and again.
Okay, thank you. Last question, Syed, how would you deal with this situation in Dubai? There's a lot of mixed moving populations around in your location, your area.
So the disease, the outbreak is controlled now in Dubai and the UAE. The number of cases we've peaked several weeks back. So currently we rely on symptom-based assessment along with a series of epidemiological questions. So we have two sets of assessments, one through the telephone, as my colleague just said, and the other set is on site, just like what's happening in Otago. When the patient comes, there's another set of assessment. And the same applies for the caregivers. The caregivers, they have every day to fill an electronic form asking specific questions about any of the signs and symptoms, and those who travel have a certain protocol. But it's a matter that is all related to what's happening in the local community. So for the time being, we're relying on symptom-based assessment. That's happening on 2 tiers for the patient and on a daily basis for the staff. And we'll see what happens in the fall.
Thank you very much. Thank you. Chris, if we can come back to you, what our next questions might be from the audience, please. Thank you very much.
Thank you, Albert. We're getting a number of questions on student PPE when carrying out aerosol generating procedures. So what sorts of PPE we're expecting our students to wear. But related to around how supervision of AGPs happen and the fact that individual supervisors can't wander around a clinic sort of wearing scrubs anymore and have to wear much more PPE and the sort of interactions between the same. So again, perhaps the panel might like to discuss this. If we could start perhaps with Mary on this point, please.
Thank you. Thank you, Chris. So currently, we have clinical care being provided by our graduate students. And what we're doing there are with PPE following the guidelines of the Ministry of Health, which is currently level 3 masks. And what we're doing is providing that care in closed operatories with students partnering for the care to minimize the number of people going in and out of an operatory during procedures. So what we're doing is planning for our undergrad students to do simulation. And again, that simulation will be done with PPE by staff and faculty and students. And that's to minimize social distancing measures so that we can have more students in the clinic to get that component of their educational program. And then now we're addressing undergrad students coming back for providing care. But we're following the guidelines of the Ministry of Health. I think in BC, we're fortunate that we're at level 3 recommendation. We did initially have some issues where initially the guidelines were N95, sourcing those, which was quite challenging, but the conditions of the province are such that a lower level is mandated by the Ministry of Health now.
Thank you.
Thank you very much, Mary. Thank you. I mean, in this situation where simulation is very important in learning clinical skills, in this situation, Chris, in your situation in Peninsula Dental School, would you have the same social distancing for clinical skills students, or you would say, well, they're all wearing PPE so they can be packed a little bit closer to get a little bit more in? How would you see that in your school?
Yeah, so in terms of the students, it's when they will return them actually in August. So when they come back, we're going to look at doing their simulated dental learning environment, but in not socially distanced as much because they have fluoride-resistant surgical masks on. There won't be real patients involved. So therefore, we're a little bit more relaxed in that situation as opposed to having a patient in the chair. Again, simulation has a massive role to play, but I would say very quickly that it's important and fundamental, but you can't switch simulation for treating real people at the end of the day. So again, while it's fantastic to be able to do it and great to practice skills and develop skills, yeah, it's really important to treat patients as well. So again, we've got a big emphasis on, yes, simulation is there. If a patient doesn't turn up, they can put their phantom head on the chair. If they want to practice a root canal treatment, we use extracted teeth. But again, there's no substitute for a real patient at the end of the day. So we're staying core to that as well and making sure that the students get as much experience as they can.
Yeah, thank you. Mark, what about your situation in your school?
One of the few government guidelines is that we are limited to having no more than 50% of the rated capacity of any space with students in them. So our simulation area, which is a very large laboratory with 120 stations, can only house 60 students at one time, and they're 6.5 to 7 feet apart at any given point when they're in their pods. So that's kind of how we're approaching it. Our mandates are to wear facial coverings or masks, but we don't require any other personal protective equipment in the laboratories or even in our classrooms when we're doing small case-based presentations, problem-based learning, something like that. But we can only have half the number of students in our spaces that would be normally allowed. It's interesting because in the US, the healthcare facility is exempt from social distancing.
Yeah. Right. Okay. Okay. Yeah. Okay. Corrado, what about the situation in Russia?
Well, of course, as Mark was saying, we have the social distancing rules similar to the American ones. And I think that we have to consider really what Christine was saying about blended in a different way. We know already that TEL can enhance learning in some way, but we have never used it because it was easier to have the real patients. Now we have to find a new way to integrate different aspects. Of course, as Chris was saying, nothing can substitute totally the patient treatment. So we have really to blend our resources in a different way, in particular, considering that the cost of different aspects now is changing. A lot of schools, in particular my school, was providing a huge number of treatments in order to be on the safe side of the economic situation. Nowadays, I think that we are changing towards more simulation in order to fulfill the competence requests, but also to accommodate the social distancing.
Yes, it's a very, very fine balance that everybody has to strike in different schools. And I mean, if I may turn to Alistair in Melbourne, how would you see this balance play out in the situation that we are faced with every day?
It's an interesting one, and listen to what Chris has been saying, and Corrado and Mark and all my colleagues. I think the blended approach is something that I think we have to really look at very carefully and adopt. So I've created a dental education innovation unit within the school to look at that, so we can actually look at what's worked well. In the past sort of 4 to 5 months where we've been out doing online learning, we've learned a lot. I think all of us and all our colleagues, those listening as well, will have learned a lot of what's worked, what hasn't worked, what we can share. And I think now is the time to actually share those educational experiences, because we can do a significant amount of case-based learning online For our first years, we were having them do a lot of dexterity work at home. Origami became quite a big thing for our students, and that was based on an idea of one of my colleagues at our Bachelor of Oral Health program, or moving rice with chopsticks from one bowl to another with the wrong hand. There are things that we've been able to do, and going back, I know some of us will remember the days of carving teeth in soap. We've been having students doing that at home as well. So things work. You can't substitute for the real patient. And I think we're using our simulation, our haptics lab a lot more, and we'll use it a lot more creatively. The concern for me is about the patient footfall. So whilst we want to get our students treating the patients that are there, are those patients going to be returning for treatment in the same numbers as they were prior to the start of 2020? And that is a concern for me. Do we get that patient footfall?
Yeah, it's a clinical experience again. So, Christine, what about the situation in Cork there?
Yes, I would agree with what everybody else has said, and particularly in relation to there is nothing like treating the real patient. We are very concerned, though, because the particular patient cohort that we would tend to see would often be the older patients looking for dentistry in the hospital situation that they might not be able to afford in private practice. So they're going to already be in the vulnerable patient groups for COVID-19. So that is a consideration and a worry for us that our footfall may be down of necessity, and we're looking at all kinds of innovative ways of trying to get other cohorts of people in for our students to treat. But I am somewhat concerned about that, and we'll have to keep a watching brief on that and see how things develop.
Okay. So I'm looking at the clock. We have approximately another 9 or 10 minutes maximum. So, Chris, can we have one more question, please, from you? Thank you very much.
Thank you, Albert. I think an interesting question which is coming through relates to supports for staff and students. So quite a number of students and staff have been self-isolating for over 3 months now, studying and working from home, and some of them are very nervous about returning in a cocoon to a profound level. Do the panelists have any views on how return to school work should be managed? Perhaps, Mary, you'd like to speak about this, because I know you touched on this in your presentation.
Yes. So thank you, Chris, for the opportunity. I think this is one of the critical areas of the global pandemic that academic institutions need to address. Fortunately, at UBC, our president, Santa Ono, is very attuned to looking after the mindfulness of our community, both faculty, staff, and students. So there's a number of programs that have been launched for support, as well as within Canada, there's the National Support Hotline that's available for wellness. But there's many pressures that I think we don't think of initially with online learning. In British Columbia, all the school children are at home. So our faculty are working at home, but in context to also being care providers for their families. And in many cases, the elderly within their families as well. So the integration of online learning with even resources of computers, internet speed, I think all needs to be addressed. And fortunately, our university has been very proactive in that way. But I would suggest to everyone, the people component of our educational programs are very critical, and we need to look after our faculty, staff, and students.
Thank you very much. Syed Bakane, would you like to say what your experience is in Dubai and UAE?
Yes, I think that's a very important issue. And we've been very fortunate in the university. We have a supporting staff. We have a fantastic psychologist on board, supported by a psychiatrist as well. But it was sort of extremely important to keep the communication channels open across the board, either through town halls, mindfulness session. Today we have a fantastic one for staff and for students. We offer cognitive treatments, support groups, also a one-to-one sort of support if required. Add to that, engaging students and staff with extracurricular activities. And that was extremely important. And for us, we do have international students. So some of our students were stranded abroad. So it was very important also to keep communicating, whether through academic advisors, through program directors. So I think this is something which will be required. I think going back to Mary, one of the challenges we faced as a postgraduate, some of our students are mothers with young kids, you know, having to teach the kids, yet having to comply with the schedules online. That proved a real challenge and caused a lot of stress for some of our students, but something that we have managed to pick up early and provide flexible sort of scheduling for our patients. But yes, I agree that this is something that will be with us and an essential component of delivering sort of healthy education.
Thank you very much, Syed. What about the situation in Hong Kong then, Kong? Would that resonate with any of your experience as well, with the city very, very densely populated?
Yes, indeed. We had the problem when we had Chinese New Year. There was a few students went abroad for holidays, so we have to reach out and then connect with them, making sure that they stay safe, and then able to come back at the right time, because we started school at late May to start again, considering all the quarantine they have to go through. Regarding graduate students, we had the international graduate students, so we also have problem in them stranded somewhere. We had some students still in abroad, so we have to reach out to them, talk to them, think about the situation and try to make ways to work out how they graduate, particularly those final year students, if with or without critical case and so forth. One other point I want to mention is that interestingly, we have experiencing a bit of problem in our research lab because we in a dental school or clinical school, we had a lot of clinical specimens. So the faculty has to spend way to walk our colleagues through the way that it actually is safe, it is still okay to handle clinical experiments, samples, and so forth. That was a bit of surprise because we didn't know, but I think perhaps we or the rest of the faculty are more sort of clinical. We didn't know about that, but for the lab people, they obviously are more sensitive about this issue. But anyway, I mean, we walk through them. We walk through this problem as we speak. We still have some students. Yeah.
Thank you very much. Carl, Kern had just basically specified quite a lot about what students would do, different sphere would do, laboratory people would do in terms of shooting and coming back. And what about the situation experience you have in New Zealand? Would there be any difference, I think?
It was a little bit, Albert. And while Alistair can't hear me, for Otago and Melbourne, we went into lockdown early in our academic year, as opposed to in the latter part of the academic year. And during lockdown, which was for around 8 weeks or so, myself and our Dean, Mike Morgan, maintained weekly contact with the student executive. And it was very interesting that initially in lockdown and talking to the students would say that whatever it takes, we'll do it in order to graduate on time. But through the period of lockdown and not being able to contact with friends and family and the like, towards the end, the tune changed to whatever it takes so long as it's comfortable. And so for us, when we returned to school, starting with our final years and senior students and graduate students, to start with, they will all express a sense of relief to be back. Also with our undergraduate students, we started with simulation, which they also appreciated primarily because they'd been early in the academic year before we moved on to patient treatment. And so for us, what we found, same as the other schools, is that regular contact through lockdown was really important. We also found that online learning worked pretty well, but internet speeds, internet availability and the like were certainly issues that affected some students that we hadn't necessarily anticipated. And running online exams, also for our end of semester exams, we got there, but it wasn't straightforward to do that.
Okay, thank you very much, Carl. Christine?
Yeah, I just wanted to make the point, Albert, that our concern for our students' mental health is very important, but I think I would be concerned at the moment for the staff. They've been working incredibly hard since this started, and it's coming up to the traditional summer break for us here now. The university is taking a 4-week kind of rest period when things are going to go very quiet. Well, for us, for many of us, I really don't see the chance to do that. So that's a real worry that people are going to be going into the new academic year with all these new challenges, exhausted at the start, and that's something we really have to look at. We're persuading people to take breaks, but it's difficult. They don't want to do it because they've so much to catch up on, and we are a very small faculty and very much under-resourced, so it is a problem.
I mean, I completely agree. I mean, personally, then I've been paddling harder than ever, just even to try to stand still or sit still there, even worse. Last question now, Chris Stratton. In your situation as the incoming head of the dental school councils in the UK, how do you think UK dental school in general will see this particular question? How are they going to balance that?
I think all the points around the room about the staff and well-being is really vital. Is that they've got to take their breaks and they've got to have a rest, because otherwise, as a team, we're just not going to make it through this next year. So it's really encouraging staff to have the breaks, make sure they're supported appropriately, and really and try and just get them to have as much rest as possible. Be absolutely right. It's vital. It's been recognised by the universities as well that staff are key. And if the staff are tired and can't cope, then we're not going to get where we want to get to. So it's vital that they take their breaks, and vital that we support them as much as we possibly can for the future, along with the students, of course, as well.
Thank you very much, Chris. And on this note, then I would just like to thank the panel members, all my very distinguished colleagues from all over the world, particularly from Alistair and Carl, who is staying up well beyond normal bedtime to stay out with us. Thank you very much. The coffee and something stronger really worked very, very well. And good morning to our colleagues in the West Coast of America and others, and to Europe and Colorado and Hong Kong and Sayed and everybody as well. It is a very, very good and fruitful discussions that we have, exchanging all the ideas, exchanging all the opinions and everything. I hope that everybody taking part has found this particular live question and answer session very, very useful. Of course, we're going to try to do that again in the autumn time by Royal College of Surgeons in Ireland. I'm very, very thankful of my colleague, Professor Chris Lynch, who looks after many of the questions behind the scene and everything as well. And for your audience, I'm going to hand over to Chris now, so that you will have the next 3 presentations, which you will hear in just a minute. Thank you very much.
I would now like to introduce Professor Wai Kyung Leung, who is Clinical Professor in Periodontology and Coordinator for the final BDS examinations at the Faculty of Dentistry at Hong Kong University.
Good day, ladies and gentlemen. It is my great honor to be invited by the RCSI for this webinar session, going to share with you our experience of dental education under the influence of the COVID-19. In your right-hand side panel, you can see the situation, the distribution of the COVID infection since day 1, and the top hand corner. And you can see that we up to now, we had the 1,300 plus infection in Hong Kong everywhere, with the red dots indicating the new infections. As we speak now, we have more red dots happening. regarding the COVID-19 infection, we had the media cover since December last year, and we had the first reported case brought into Hong Kong in mid-February. By then, a lot of Hong Kong people lined themselves up on the street overnight to buy face masks, hand sanitizer, and so forth. Up till now, we have accumulated 7 deaths, and many of the infected are out from the hospital. The first infection in the community, i.e. for those we cannot find a clear source, started at late March and early April. Then later on, the city has been reasonably successful in putting down the infection. So the government is announcing that we go back to school in May 22nd. Actually, after the Chinese New Year, where the infection landed in Hong Kong, the school has been stopped. Then that's the same case for the Hong Kong dental school. We have no face-to-face education. Later, late May, the government found the situation is quite good, so they ordered the secondary pupils go back to school. This is exactly the same time when we allow our dental students to go back to the dental hospital. But a couple of weeks later, then we resume the BDS clinical education. Unfortunately, as you can see from the lower panel, the slide, actually over these few days, we're experiencing the second wave of the infection, so we are not too sure we have to suspend the school again. Regarding the impact of COVID in general practicing dentists in Hong Kong, that indeed there's a lot of effect into this our practice. Our colleagues had to arrange longer appointments to reduce gathering at reception. More time, obviously, for us to put on and put off the PPE, cleaning and disinfecting the surgery between patients. We also have to ask the patient to fill a health questionnaire, temperature check, and then everyone has to wear face masks, surgical masks, before entering the premises of the dental surgery. Shortly after that, they will have to given hand sanitizer to disinfect their hands. At all times, the patient will wear face masks until we start the examination and treatment. For all healthcare provider, we wear face shield, eye protection, N95 mask or equivalent, head cap, and so forth. Before receiving any examination and treatment, the patients will have to rinse their mouth with chlorhexidine, hydrogen peroxide, and etc. And obviously, our colleagues will arrange four-handed dentistry to help control the moisture, etc. during the operation. To aid that, many of our colleagues, they purchase equipment like you can see one example of such device here, and then it is in action. For some more concerned practitioners, they will also equip themselves with UV lamp. So during lunch hour and after office hour, they will turn on the lamp so that they can disinfect their surgeries. How about the situation in dental school? How we work with the situation under COVID? Well, we had a brief pause during the Chinese New Year, and then the university has been busy getting all the license for this software reasonable, like Zoom and Panopto, for us to advance the didactic teaching during the school suspension period. And then during that period, between our education, we keep good contact with the student, and then we will make electronic connection with them via Zoom or email to make sure that they are safe and then they have no problem, particularly with the learning and etc. in between, we also have emergency dental service open for all patients, including the students' patients, so they can feel free to refer the patient to us. And also, we slowly practicing how we manage our infection control with this smaller number of incoming patients. We also are very busy having a lot of meetings looking at the missed learning opportunities. So we will figure out how we catch it up once there is opportunity available. And thanks God, we had this opportunity at the May 27th. So we have the SIMLab testing, SIMLab teaching back to normal in such a way that the student will learn how to put on the personal protection equipment as shown in here, so that they have some preparation before they go back to the clinic with the patients. Shortly after that, we get our senior master student back to training. Again, with that, we increase the size of the clinician in the clinic. So we slowly but surely understand the procedure, the things that we needed for the training to happen when we become full sprung. The recent progress is that we are preparing the student, and then we do COVID tests. We have temperature check in the front door of the hospital. We visit the clinic looking at how we improve from the old design, which is non-COVID preventing, to how do we work it out. So for example, in the time being, we divided the clinic in two zones, one zones with patient 3 meters apart, and then behind that, in this case, we had chairs not used. We designated clean zone, so where the student can do the paperwork, and in the dirty zone, the student can work with the patient. We have more students than the ADSA, so we have to reschedule the timetable and so forth. By June 22nd, all master training resumed, and then a few days later, we resume the dental students' clinical teaching. We start with the senior years, and then later with junior years. Also, since the student did not finish the academic year, so we have to have them go through assessment, so we are modifying our assessment, so the social distancing and so forth is preserved. How will we go about it in the future? Actually, what happened in Hong Kong is the Hong Kong people has experienced SARS-CoV virus 1 in 2003. At that year, we lost 300 lives, including 8 medical workers. So it was a hard lesson for us. I suppose with the current more infectious COVID, that we have to be sure that we have to live with this situation for a long time. At that time in SARS era, we have the school stopped for 1 month, and then shortly after that, over 3 months or so, we have been on high alert with all sorts of appropriate PPEs. And then we were lucky that at the end of the year, the SARS virus no longer existing. That's why we go back to the pre-COVID period. But I think from now on, it's a different ball game. We have to, including ourselves and our students, to learn how to prevent the infection, to learn how all relevant protocols to prevent and manage the situation. As we speak now, we were lucky enough not to have any one single COVID infected case entering our premises, but I'm pretty sure soon or later we are going to have one person or more, and we have to learn how to deal with that. As I mentioned, we have to reinvent the clinic layout and also the scheduling for the effective infection control in the time being, and hopefully in the long run, we will redesign all the facility so that hopefully it is more in line with the prevention of the airborne infection. I mentioned that earlier, we are going to change in the clinical training session scheduling. For example, 3 rather than 2 shifts of training sessions for the student, as well as the student has to pair up for themselves to assist, make sure that it's four-handed dentistry, because we had the DSA student ratio of 1 to 3. I don't think with that person situation is good enough for prevention of COVID. Also along that line, we have to downsize the student size. We went from 8 to 10 students per group to 6 students per group. We are experiencing how well our teachers and students are living with the increased infection control requirement, as well as the quality of the education at the clinic side. And so far, this is the update of our situation from Hong Kong. I thank you for your kind attention, and please kindly share with me your comments and questions if you have any. Thank you very much.
The Faculty of Dentistry at the Royal College of Surgeons in Ireland greatly values its links and association with the local dental schools. I would now like to introduce Professor Chris Irwin, Associate Director, Centre for Dentistry at Queen's University Belfast, who will introduce our next speaker.
Thank you, Chris. My name is Chris Irwin. I am the Associate Director for Restorative Dentistry in the Centre for Dentistry here in Queen's University Belfast. I would like to introduce Professor Carl Lyons, Professor of Restorative Dentistry at the Faculty of Dentistry in the University of Otago in New Zealand.
Hello, good evening. And I'm really pleased to have been invited and to have the opportunity to present at this back to school webinar, COVID-19 in New Zealand, the University of Otago Faculty of Dentistry experience. I'd like to talk about the experience of COVID-19 in New Zealand. We had our first reported case here on the 28th of February, and the number of new cases peaked in early April with 89 new cases reported in one day. And at that particular time, there were 929 active cases of COVID-19 in New Zealand. Between the 22nd of May and the 16th of June, we had no reported new cases, and we currently have 22 positive cases of COVID-19, all in supervised managed quarantine. New Zealand has had a total of 1,533 cases of COVID-19 and 22 deaths. The majority of these were from residential villages around New Zealand. Before we entered into the lockdown phase of COVID-19 in New Zealand, the government introduced a 4-level alert system that was first proposed on the 21st of March. And this was initially set at level 2, but we moved to level 3 on the 23rd of March. And 2 days later, on the 25th of March, we moved to level 4, which put New Zealand into a nationwide lockdown, which essentially meant that everyone was required to be at home, other than to go to shop for essential items at supermarkets or local dairies, or for essential workers to travel to work. We moved to level 3 on the 27th of April, which partially lifted lockdown restrictions. And then a couple of weeks later, on the 13th of March, we moved to level 2 that lift all of the lockdown restrictions while maintaining the requirement for physical distancing of 2 meters, and also maintain limits on the size of gatherings. And on the 8th of June, we moved to alert level 1 that essentially removed all restrictions other than border controls. At the University of Otago, the experience for us in the Faculty of Dentistry was that our clinics ceased operating other than urgent clinics on the 23rd of March, on the day that we moved to alert level 3. The university closed to all but essential workers 2 days later on the 25th of March, when we moved to lockdown at level 4. We did, however, move relatively quickly to online teaching with the introduction of online teaching approximately 1 week later, that was phased over another couple of weeks to be introduced across the whole university. And the university carried on with all semester assessments online, as well as exams and final exams for semester 1. Once we moved to Alert Level 2, our final year dental students returned approximately 1 week later on the 18th of March, and our final year Bachelor of Oral Health students returned a week later on the 23rd of May. And both of these classes commenced with 2 weeks of simulation prior to starting with patient clinics. On the 23rd of May, our graduate students, so our Doctor of Clinical Dentistry students, Master's students, and our postgraduate students in Clinical Dental Technology returned to clinics, and these have carried on since that date. Our final year and graduate students worked through what would have been our June-July inter-semester break between semester 1 and semester 2. And during the inter-semester break, our third year and fourth year dental students commenced studies again, starting with simulation, as well as our Bachelor of Oral Health students. And then finally, our Bachelor of Dental Surgery second year students and our Bachelor of Oral Health students recommenced study at the university at the beginning of semester 2, which was the 6th of July. And also our Bachelor of Dental Technology students also returned to laboratory study on the 23rd of May and continued right through the inter-semester break. For us in dentistry, providing oral health services was determined by the guidelines that were provided by our regulatory authority, the Dental Council, as well as our Ministry of Health. When we moved to level 4 and then subsequently to level 3, in New Zealand, we were only able to provide urgent or emergency dental treatment. We were required to undergo telephone triage of patients to determine whether it was possible for us to treat the patient or whether it would be possible for us to manage problems that the patient had, say by prescribing antibiotics and pain relief if it was to manage pain, or if it was to manage orofacial trauma. If it was determined that we weren't able to manage these conditions by phone, then we would arrange to see the patients. If we were seeing low-risk patients, treatment could be provided in a single-room dental clinic under normal pressure with a closed door, wearing surgical masks at level 2 or above, with gloves, as well as eye protection that were safety glasses that have carried right through, safety glasses that had side vents, or goggles or prescription glasses covered by a full face shield or visor, as well as long-sleeved impervious gowns. For high-risk patients, we were able to provide treatment if it was necessary in a surgical bus that was parked outside the dental school that had a negative pressure room, and we were required to wear N95 or FFP2 masks, as well as gloves, same eye protection, and long sleeve impervious gowns. Once we moved to alert level 2 and 1, the restrictions that were on us were significantly less, and we're able to move to providing routine dental care for low-risk patients, as well as continuing to provide urgent or emergency care for high-risk patients. Patients had to undergo a COVID-19 epidemiological question in order for us to screen the patients prior to them receiving an appointment. And as you can see on the screen, the epidemiological questions really moved through a sequence where we asked patients if they had a confirmed diagnosis of COVID-19, or were they awaiting the results of a COVID-19 test, had they been in contact with anyone that had COVID-19, as well as some health-related screening questions, such as did they have a cough, a sore throat, shortness of breath, runny nose, or loss of smell. As well as that, we had some questions that related to overseas travel that you can see on the screen relating to travel in the last 14 days and so on, which really for us were just straight screening questions, primarily because international travel had been very largely restricted and that only New Zealanders or New Zealand residents were able to travel into New Zealand. And on travelling into New Zealand, it was required to undergo managed quarantine. In providing treatment for patients at alert level 2 and 1, we were provided with guidelines from our regulatory authority and the Ministry of Health on the treatment that we're able to provide it and how we would provide it for low risk and for high risk patients. So as you can see on the screen, low risk patients we're able to provide both routine and emergency or urgent care. These were able to be provided in a single room dental surgery, but could also be provided in a more open clinic like we had in our clinical services building in the Faculty of Dentistry. We're able to provide treatment for low risk patients that generated an aerosol. And for low risk patients, we're required to wear a level 2 or above surgical mask, eye protection, as I've already talked about, as well as gloves and outer protective clothing that protected the clothes that we were wearing underneath. Essentially, though, at level 2, we were able to provide any kind of treatment, ideally using rubber dam where that was possible, and where possible with a dental assistant available that would use high volume suction to minimize the generation of an aerosol. For high risk patients, we were only able to provide, and we're still only able to provide, urgent or emergency care. And if we're providing non-aerosol generating treatments for high risk patients, we can do these in a standard dental surgery with standard protection. But where an aerosol is being generated, we're required to wear N95 or FFP2 masks, as well as eye protection and long sleeve impervious gowns in a negative pressure room. In providing aerosol generating treatment for low risk patients, we're asked to close the door where possible and to carry out measures where, as much as possible, we reduce the extent and contamination from aerosol and splatter, which would involve using high volume suction, using rubber dam where we can, and asking patients to use a pre-procedural mouth rinse, which here we're using a 1% hydrogen peroxide mouth rinse. In terms of some of the other questions relating to oral health services under Alert Level 2, there were some specific questions that we were asked to consider with respect to the New Zealand experience and specifically what we're doing at the Faculty of Dentistry. So in terms of PPE and specifically masks, for low-risk patients right the way through, we've been using a surgical mask at a level 2 or above. But for high-risk patients, we're using N95 or FFP2 masks. But for all patients, we're also wearing gloves, eye protection, and for high-risk patients, we're using long-sleeve impervious gowns where treatment's provided in a negative pressure room. And for low-risk patients now at Alert Level 1, we're just using regular outer protective clothing, which can be long sleeve or short sleeve in a regular dental practice. As I've mentioned in the previous slide, our students are able to provide aerosol generating procedures, and they're trying to carry these out as best as possible in a way that minimizes the amount and extent of the aerosol and splatter, and they're doing this where possible using rubber dam, but it's not a requirement for us to use rubber dam. And with the help of an assistant, again, where possible, using high volume suction and using a pre-procedural mouth rinse with an oxidative agent, which, as I mentioned, we're using 1% hydrogen peroxide. In our case, we've not been required to make any room modifications, and we're quite fortunate at the University of Otago with our brand new clinical services building, which has been open for just a little over 1 year. We've also not needed to introduce special air filtration or air exchangers, again because of the state-of-the-art nature of the clinical services building that we're working in now. Have we required a stand-down period between appointments? No, we don't, other than if we have provided treatment for a high-risk patient where we're required to stand down for 20 minutes only. Our experience, though, is that we haven't had to provide any treatment or any dental treatment to date for a high-risk patient. We've also not needed to split our students and staff into teams to manage the potential risk of seeing a COVID positive patient. And at the moment, we're not needing to consider that because we have no community spread of COVID-19 in New Zealand. And did we move to online teaching? Yes, we did. We moved to online teaching very soon after we moved to level 4 in New Zealand on the 25th of March. And this continued right through the remainder of the first semester of our teaching at the University of Otago and right through the inter-semester break. But now that we've moved to the second semester of our year here at the University of Otago, we've moved fully to face-to-face teaching. Thank you very much for listening to my presentation on the experience of COVID in New Zealand and how that has impacted on the University of Otago Faculty of Dentistry.
I would now like to introduce Professor Will van der Sanden, who is Programme Director at the Radboud University Medical Centre at the Department of Dentistry in Nijmegen, the Netherlands.
Good day. In my short presentation, I will share my thoughts with you about the effects of COVID-19 in the Netherlands for the Dutch dentists and what happened to my dental school. The Netherlands approach is aimed at keeping the virus under control as much as possible in order to protect vulnerable groups and make sure the healthcare system can cope. Therefore, an intelligent lockdown started at March 12. This included working at home for everyone as far as possible and limitations for groups of more than 100 persons. People movement should be reduced as far as possible. This was followed step by step by more governmental restrictions, including closing dental schools, pubs, sporting centers, etc., etc. Thanks to the Dutch people complying with these measures, the numbers now show a very positive decreasing trend. However, it is vital that we stay in control of the virus, thus we still keep the 1.5 meter distance and stay at home in case we don't feel well. What happened in dental practice? The Dutch Dental Association recommended a complete lockdown starting at the 16th of March 2020. Only emergency treatments were offered by all dentists for those patients who did not have any COVID-19 infections and passed the triage. This means they had to answer few questions about COVID-19 symptoms. Only those who answered no to all the questions were allowed to visit their dentist. In a very short time, about 2 weeks, the clinical practice guideline, COVID-19 and oral healthcare was developed by CHIMO, the Dutch Guideline Institute for Oral Healthcare Professionals. This guideline described the measures to be taken for safe treatment of patients and to protect the oral healthcare professionals. Normal face masks, type 2R, were used. Some used an additional face shield and still do. Within 2 weeks, the Dutch Dental Association managed to open 11 camps. These are corona centers for urgent oral health care all over the country. These are dental practices that offer emergency care, especially for COVID-19 infected people with severe dental pain. These centers were closed from the 1st of July this year. And as far as I know, the frequency of patients' visits was very, very low. On average, 1 patient per week per center. All dental offices started reopening from the 21st of April on. On the other hand, the dental schools remained closed. What does it mean for my dental school? Well, the university ordered us for a complete lockdown starting at Friday the 13th of March. Really an unlucky day for me. Closing all universities was additionally ordered by the Dutch Minister of Education in order to prevent student mobility and thus preventing COVID-19 to spread. So I had to close my dental school, including the preclinical skills lab, as well as our student-run dental clinics. A real disaster, not only for my students, but also for almost 12,000 of our patients. Staff members were asked to offer emergency treatments for those patients who did not have any COVID-19 infection and passed the triage questions. In a very short time, about 2 weeks, we managed to change our educational system from live lectures at our school to virtual classrooms. The main impact of closing the dental school was on the last year's graduation students, as they had to stop the patient's treatments and could not finish their last treatment. Our student-run dental clinic used a programmatic assessment approach, so we exactly know the present skills of our students. Furthermore, the last 3 months of their study are mostly used to finish their thesis. Although it had much effect on their study, at the end it was minimalized, I think. Moreover, we had to change our exam system for theoretical courses, as it was not allowed to take any exams at the university anymore. As a pilot, we used digital testing with online live proctoring, using a computer program for distance testing called Cirrus with Proctorio. Maybe you know it. But this resulted in many student complaints, mainly because the impact on their privacy. So we decided to use a kind of take-home exam or open book exam, in which students got their exam mailed and had to return it within 1 hour. This was very well accepted by staff and students, as we tested insight and capacity to use the knowledge instead of just testing knowledge. The Dutch healthcare minister decided that all medical and dental schools were allowed to restart at the 15th of June. Due to all COVID-19 regulations, only 1/3 to half of the places in my skills lab and dental clinics are now available, as we have to keep the 1.5 meter distance. In the skills lab, our students use disposable plastic aprons and surgical type 2R masks. But if they want, face shields are still available. We offer these aprons in order to prevent unnecessary student movements in the changing rooms. The photo shows a very usual, colorful picture of the skills lab. However, in our student-run dental clinics, our students use normal clinical clothing, surgical type 2R mask and gloves. All patients should pass the triage control at the entrance before they are allowed to enter the building or even the clinics. They have to disinfect their hands. As we lost almost 3 months of education time, we offer our students extra time in the skills lab and student-run dental clinic during summer vacation, although we urge them to keep at least 4-week break for recovery. We have to remain the virtual classrooms, as we are still asked to offer classrooms as much as possible on a virtual way. In addition, we will change our current system of testing. I assume we can increase the number of students in the skills lab and clinics during autumn to regular figures if the situation in the Netherlands remains stable. But at the end, the normal number of students could graduate at July 3rd this year. To end up with some frequent asked questions, we will use the normal surgical mask type 2R for all patients who pass the control. Only those who are COVID-19 affected and need urgent treatment, we offer special masks and disposables for our staff. Students will not see these group of patients. For aerosol generating procedures, we ask patients to rinse their mouth for at least 1 minute with 1% H2O2 in order to reduce the viral load. In addition, we recommend using rubber dam, and our students have to work with a dental assistant or as a pair in order to reduce the aerosol load. For air filtration and cleaning up of surfaces, we use the normal procedures. As we have to reduce the number of students in order to keep the 1.5 meter distance rules, we only need about half of the staff too. We've learned a lot. We had to change many things within a very short time. Some failed, some showed to be a success. I think we should at least keep the virtual classrooms as we record these. It helps our students to study at the time they want. Thank you for your attention.
Ladies and gentlemen, I hope you had enjoyed the webinar today, brought to you from a large number of significant dental schools around the world, with experts delivering the opinion and discussions. We hope that you have found the webinar beneficial, you have found the experience useful to you. I would just like to thank you as participants for taking part in this webinar for us, and also my colleagues at RCSI who have worked so hard in planning, executing this particular event. It's a remarkable team effort. And talking about team, I'm very, very grateful to all our guests for coming from all 4 corners of the world to give us their expert opinion on this very pertinent subject. I cannot go away without thanking the very, very people who make this happen, our colleagues at Redbox Video. You guys have been marvelous in helping us to make this event possible. Thank you very much indeed for all your expert help. To our audience, please don't forget to fill in the feedback form for your CPD certificates. And thank you to you all. And we look forward to seeing you again very soon. Keep safe, keep well in the meantime. Goodbye from me.